the session.
Good afternoon, everybody. In the absence of our chairman, S.K. Satish, we have with us the founder, Professor J. Srinivasan, distinguished audience. On behalf of the DVHS Center Climate Change, Institute of Science, Lakeside Education Trust, and the International Pediatric Association, Geneva, this is a monthly program. We have been doing this is the 4th year, starting from January. Various topics which are related to the global and the national level, we'll take it, we'll discuss. And also these ideals were been printed in our bulletin. It goes across the, and whatever we talk, it goes to the YouTube also. And this is what we have been doing this 4th year, first topic. And this topic, this month program is International Quality of Day Celebration. So quality of healthcare celebration without palliative care, the importance. That's why we selected the role of palliative care in the current healthcare environment. Usually the last Thursday we used to do it, the regular feature. This month we have started only on 18th, mainly because we have been invited to go to Kerala. My associate Joshita is there. Both are invited as a faculty for the National Convention, 61st National Convention of the Indian Academy of Pediatrics in Cochin. For 5 days is a conference. Nearly we are about 45,000 pediatricians across the second biggest in the world after American Academy of Pediatrics. And also the theme is also something at the environment. Global warming, children's health for this theme. So they have a conclave for us, only both of us are invited to address, we go there. That's why we have to prepone, and thank you very much. And Srinivasan always there stand by us to helping us. This is what it happened to us. Now, to formally to welcome all of you, we have none other than the person J. Srinivasan, who started this program 2011, the BHT Center Climate Change. And he is the man, did his technology work in Chennai, and then went to Indian technology there, then went to New York University, then the Stanford University, and worked in NASA also. And he came back, built this institution. And now he is the distinguished professor, is a man with action. He speaks less, but definitely is a man with action. What he preaches, he practices. That's what I learned. And the medical people coming here, he is one of the visionary. Himself, Satish, insisted to be joining here. This is the 5th year I've been as a medical man. First medical man, second person is here. So we are taking it. Our aim is to propagate the knowledge, the climate change, and all this thing. That's what we have been doing it all around. In this kind, and Srinivasan, and do you know, we say that we have to reduce 2 tons of carbon footprint every person globally, even though we produce less than what it is in India. So the recommended is that America produces about more than anything else. And globally is only 4.5 tons they're producing. So he walks from his house to here, Srinivasan. And he's a good human being and always encourages the value-based research and all this thing. He never restricts anybody to go move forward thinking in that line. And more than that, he need not say about it. He has got his own ideals. He is none other than, his uncle is none other than Nobel laureate Sir C.V. Raman. So, sir, it's a great honor. Welcome you all. Welcome me here to invite officially for all the delegates. Thank you very much, sir.
Good afternoon. I would like to first congratulate Dr. Paramesh for carrying out this health and environment related seminar series for the 5th year and organizing a talk every month without a break and covering a wide spectrum of issues. Although the broad theme is health, climate change, and environment, he has covered various issues. We had, I think, a talk last month on toys, right?
Yes.
And today we are covering a topic which is normally a taboo in our society, is palliative care. Okay? Because in our society, for a long time, at least in my generation, it was assumed that it is the job of the family to take care of the older people or people who are sick, and not a society. That's our tradition. So that is breaking down now. You can see all over the place, especially where I live in Malaysia, old people living alone, their children are somewhere else in the world. So this palliative care is getting to be more and more an important issue. And so it's very nice that Dr. Paramesh invited Mr. Nagarajan to tell us about palliative care in India. And so I look forward to hearing from him. And I request Dr. Paramesh to introduce the speaker. Thank you.
Thank you, sir, for your kind words. And once again, I have the pleasure welcoming you all for this session. And the next item is the introduction of the topic, sensitizing the topic, and the introduction of the two speakers, what we have here. And palliative care is a specialized care to relieve the symptoms, stress, and providing the comfort and support to an individual with serious health condition to improve quality of life, unlike hospice, which people often associate with the end of life care. Who can provide this one? Like various groups are there, health professionals, medical doctors and nurses and everything, social workers, like here, financial advisors, spiritual advisors, service clubs, social clubs, and nutritionists. Anybody can provide it. Where it can be provided, even it can provide it at their home. Whether the person is at home, is at clinic or hospital, in etc., we can do it. And also it equips the family and caregiver to support them also while taking care of themselves also. However, there are various myths about the palliative care. One is people believe that it hastens the death, that's all. Palliative care to hasten the death. That is a misconception. We have to clarify that doubts here. Only for person who is dying of cancer, only for that person only. That's also not true. People who stop eating, they die for starvation. They make them to starve, they die themselves. It is not true. This is related. That providing only in hospital, which is not true. I mentioned about it. Avoid children not to involve in the talks. I think that's also myth. We have to highlight that one. How to involve in the children. Pain is a part of dying. What are we worried about it? Let it go. That is not a right thing. Pain medication leads to addiction. Unless you're giving the medicine, it leads to addiction, they'll die from addiction, which is a myth. It's not really a fact. Morphine is used to hasten the death. It is not really true fact. My doctor is given up hope. My doctor has given up hope. What can I do? Let me die. That is a myth, not a fact. So not dying at home is letting down your family. I would rather die in my home, not in. These are all the myths. And we have people to clarify these myths. What is the fact? We are going to learn about it. To talk about these issues, we have two experts with us. One is Professor Dr. B.S. Nagarajan. B.S. Nagarajan is a strategic technology leader with 27 plus years of experience in customer facing roles such as pre-sales, customer success in enterprise technology companies such as Salesforce, VMware, HP, Compaq, and Wipro. He is widely acknowledged as an inspirational leader with a positive influence on people to do their best work every single day. He is the founder of the managing director of the Sukriti Charitable Trust, what you have been seeing it here, which is supporting hundreds of people by reducing their burden on healthcare. He is extremely passionate about philanthropy with a strong belief that is not meant only for the rich, but every person can make a difference in somebody's life to make this a better world. He and his wife, Kavita, together have committed a significant part of the earnings to provide palliative care services on a fully charitable basis. First, he is going to speak about 10-15 minutes, followed by we have another expert here, Dr. Seema Rao. So she's from my medical college, Mysore Medical College. So we are happy to say that. And Dr. Seema Rao completed her postgraduate studies in psychiatry in the year 2001 from Rajiv Gandhi University Health Sciences, Bangalore, and completed her master's in palliative care medicine with a distinction from the Cardiff University, United Kingdom in the year 2019. She has awarded Commonwealth Scholarship to pursue her MSc in that subject. She is an Associate Director of Education of Research, Bangalore Hospice Trust, Karunashaya Institute of Palliative Care, Education and Research currently. She is the Faculty of Cancer Treatment Centers Program, Leon Collaborative for Palliative Care in Singapore. She is the National Faculty, Indian Association of Palliative Care. She is a Central Council member of South Zone, Indian Association of Palliative Care. She has published many peer-reviewed articles in the journal, I think 24 or 34 around, yes. And her research work, she received many awards for her research work. We have a great pleasure inviting her also. The first topic would be role of palliative care in the current healthcare system. That will Professor Dr. B.S. Nagarajan, Managing Director, Sukriti Charitable Sir. Sir, over to you. Welcome.
Thank you, Dr. Parmesh. A small confession. I am neither professor nor doctor. You've been very kind. I'm just B.S. Nagarajan. As he introduced correctly, I am more of a technology leader. I wish I can be called as Dr. Nagarajan someday, but anyway. First of all, thank you, Dr. Parmesh and Professor Srinivasan for this opportunity. It's an honor to be speaking at the Indian Institute of Science. I was telling him that I have had the privilege of visiting this campus several times in my earlier avatar when I was working for other companies. But I think this is a very different role that I'm playing today. About 6 months ago, seven months ago, I quit my professional career. I was working for a company called Salesforce. I've spent about 28 years in the industry. And I've had a good run. God has been very kind. I've enjoyed good roles in various companies. I've earned well. God has been kind on the wealth front as well. But somewhere we realized that a lot of people like us, when I say us, it's not me, all of us sitting here, right? We have a role to play when it comes to philanthropy, right? Generally, it's a perception. The first names that come to your mind when you talk of philanthropy are people like Narayan Murthy or Sudha Murthy or Premji or people like that, right? Not necessary. It's not necessary that somebody who has millions of dollars or rupees only has to give away, right? All of us can give away and should give away. How much do we give away, in what form, time or money, that's left to us, right? But I think it's very important that we learn to give, and not just keep taking all through our lives, right? So that's the background with which I said a goodbye to my professional career, and we are now doing this full time. As you can see, we started a charitable trust called Sukruti Charitable Trust, and we have now started a palliative care center, which we will talk about later. The name of that place is called Nemmadi. Nemmadi stands for peace of mind, if you know, in Kannada, right? So again, Dr. Seema Rao is definitely in a much better position. She deals with people, patients, doctors, in the entire medical fraternity day in and day out. So hold on to hear more granular details about palliative care when she speaks. But what I will do in the next 10-15 minutes is open up this topic of palliative care. In fact, Dr. Parmesh in his introduction has already given away one slide of mine. He's already given that introduction, so we can probably move faster. Right? A quick show of hands. How many of you are already familiar with this term? You have heard about palliative care. You know what palliative care is all about? Nobody? Okay, good. I'm saying, yeah, other than you both, of course. Okay, nevertheless, nothing wrong. I'm not too surprised. I would have probably expected one or two hands to go, because unfortunately, I think the awareness levels of palliative care in our country is dismally low, right? So we've got a lot of work to do, and this is one of the things that we are doing. Like this, we'll probably will have to do, hundreds and hundreds of sessions to make sure that more and more people understand what this is all about, right? Okay. First, I would like to start with what it is not all about. And this is exactly what Dr. Parmesh spoke a few minutes ago. In fact, he had a lot more than what is there in the slide, but these are the most common ones, or the low-hanging fruits, right? The moment you hear palliative care, most people think that these are the last few days a person would live, right? This is only end-of-life care is what it is perceived. It is true and false. You will realize in the next 5 minutes as to why I'm saying it's true and false, but it is not necessarily only end of life, right? I'll give you a very practical example, or a live example. In my case, my elder sister, as we are speaking, is suffering from breast cancer stage 4, which means it has spread beyond one organ, and as a result of which she cannot be cured, right? This is what people refer to as either advanced stages or stage 4 or whatever. This was diagnosed for her about 1.5 years ago, right? And today, if I get her and make her stand here, you will say I'm lying. You can't make out at all. She's like any one of us, right? Again, thank God, that's what God has been kind. Why I gave you this example is she is one person who would come under palliative care, but hopefully she has a few years ahead of her, not a few days. So the first one is that point, that it is not always just end of life, a few days and things like that, right? The next one is again the same thing more or less, which is terminally ill patients, people who are extremely ill and have very few options to deal with, right? Not necessarily. They are also a part of this, but not always the same, right? And like you said, cancer has been more popular for whatever reasons, but this is not necessarily only for cancer patients. In fact, we were just discussing outside the hall that, what do we do for non-cancer ailments, right? There are several people who suffer from respiratory issues, chronic kidney diseases, heart-related, diseases, dementia, Parkinson's, and so on and so forth, right? Lots of tuberculosis and all of that. So palliative care refers to even those beyond cancer, but for whatever reasons, cancer has been very popular. And again, within palliative care also, there have been a lot of organizations who have been supporting cancer patients. So that myth has come, but it's not only for cancer, right? It's beyond that as well. You just said this, it's not, in fact, it should never be the last option. But unfortunately, because of the awareness, low awareness in our country, it ends up being the last option. People will try everything else, and when they have nothing else to do, there's no more hope, they've lost all the money, all the support system, nobody to take care of, that's when they will think of palliative care center, things like that, right? But that's not the case. Again, not giving up euthanasia, right? I'm sure all of you have heard about euthanasia. This is not legally allowed in India. We don't have a law. It is yet to be made a law by the parliament for allowing, treatment to be withdrawn to people where there are no chances of their living and so on and so forth, right? So there are two types of euthanasia, active as well as passive. Both of them are not allowed in India. But in the recent past, in the last few years, Supreme Court has made a few observations and judgments to help some people who wanted passive euthanasia. Passive euthanasia is, okay, active is where you use some kind of medicines to make sure end comes to a patient, right? Passive is where you don't use any medicines, but you just withdraw whatever treatments you're doing, and gradually the person, he or she, will pass away, right? So in a few cases, passive euthanasia has been allowed by the Supreme Court, but it's still very early days. It's very complicated in India because there's no clearly established law in India. But what is very interesting is Article 21 of the Indian Constitution talks about our fundamental right, which is right to live, right to life, right? You may wonder, yeah, what's the big deal? Right to live, we all have the right to live, right? But an integral part of right to live is the right to die as well, with dignity, right? So Supreme Court has, in their observations, ensured that right to die with dignity is a part of right to life, fundamental right. Right? It's not a separate fundamental right, but when you say right to life, it also includes the concepts of right to die with dignity, which is nothing but what palliative care offers. Right? So in short, if you are wondering what is this all about, this is a very popular quote from a person which says, it doesn't matter how many days, don't count the days, but how can we make those days count for the person, right? That is the essence of palliative care, right? So what exactly is, okay, what exactly is palliative care? As Dr. Parmesh read out initially, this is that kind of care given for patients who have a serious life-threatening illness, right? So this is the definition from the World Health Organization, right? This is not something that if it is not life-threatening or serious, then it would not qualify under palliative care, right? This also helps the health system, which is our hospitals and other places, to reduce the burden, because when a person reaches a stage where the treatment will not result in cure, this is called as non-curative treatment. You still treat the person, but you cannot cure the person, right? That is when the patient need not be in a hospital. The hospital can be used for somebody who can be cured, but if they cannot be cured, they could probably be taken to palliative care centers, some things like that, right? And like he said exactly, this is not necessary to be given in a center. It can be in center, it can be homes, it can be hospitals themselves, right? There are several places where people are not capable of coming all the way to the hospital. They'll be living in the rural parts. They'll have to travel hundreds of kilometers to come to a center to take palliative care. So in such cases, it's not feasible at all. So this is something that can be given in their homes as well. That's called home-based palliative care, right? So community is something that is a lot helpful when we do home-based palliative care, right? And it's also a matter of practical issue, because assume there's a husband and wife, and one of them is suffering from cancer, and the other has to look after the patient, right? He or she will not be able to earn a living if they are taking care of the patient every day at home. How do they run the family? How do they take care of children, education, fees, and so on and so forth, right? So for such people, it probably makes sense to look at some centers where they can be taken care of, right? So it can be given in all kinds of places, right? what is most important? You just saw that quote in the previous slide, right? It is to make sure that the days count, right? How do you improve the quality of life till the person lives? How can we ensure that the person can live like you and me? How can we reduce their pain? How can we take care of their symptoms, right? Lots of symptoms. If you have had any cancer patients at home, you will know what they go through, right? Either, first or extended family. And somebody was telling me recently, these days, it's extremely rare to find somebody who would not have one of their near and dear ones suffering from cancer in their families. Somebody or the other, right? Either close or a little extended families. All of us would have had somebody or the other suffering from cancer, and you would know pain is something that's very, very common among cancer patients, right? So and they can't even lead a proper life, right? So how can we make sure that we improve their quality of life till the time that they live? It's okay if they can't live for several months or years. They may live for a few days, but in those few days, can we ensure that we give them a decent quality of life? That's what palliative care is all about, right? And most importantly, this is not only clinical. This is not about giving some medicines. In fact, it is extremely less of medicines and more of psychosocial and spiritual. What does this mean? There are a lot of people, when they reach this stage, they are in a state of denial. Why did it happen to me? What wrong have I done? And maybe that person does not drink, does not smoke, no bad habits, very healthy, lifestyle, fitness, and very good person, human being. There's no rules that such a human being cannot get cancer or any other diseases, right? So it's not just medicines that will, give them care. It's beyond medicines, right? So this is a multidisciplinary approach where you will have psychiatrists, you will have volunteers, you will have counselors, right? All of them put together will play a role in ensuring that care is given to these patients, right? Okay. I'm sure you would have heard about the term called hospice. Dr. Parmesh also used this term when he was introducing us. There is something called as hospice care, right? Uh, for a large part in our country, these two terms are very interchangeably used. There's hardly any difference. The lines between these two are blurred sometimes, right? But if you actually see what this means, if you go to the original definition or practiced in the United States, hospice care is actually that end of life care. You saw that, right? End of life or terminally ill patients who have a few days, weeks, or at best a month or two at their disposal, right? That is when we refer to as a hospice care, right? Whereas palliative care is much larger than hospice care, right? That's why I gave you the example of my sister. So my sister, by God's grace, is nowhere closer to end of life as we speak today, but that is still a case of palliative care because she cannot be cured. She can only be treated to improve her quality of life, right? So how do we manage symptoms and give them a peaceful life is what palliative care is all about. So palliative care always includes hospice care. It's a part of palliative care, but not the other way around, right? But having said that, there's a very thin line. You don't have to worry too much about this, but this is more of academic interest. I just thought I'll share with all of you, right? Okay, how do we fare as far as India is concerned? Where are we in India with respect to palliative care, right? As you can see, we spoke, most of you had not heard about this. So this is one big challenge. The awareness levels is very, very low in our country, right? There is also confusion, like Doctor said, lots of myths are there. People have some wrong notions about palliative care. And unfortunately, a lot of people I have come across, they end up going to this as the last option. If only they go a little earlier, probably the patient will have a much better, feeling or a much better end to their life. See, ultimately, please understand, we all are human beings. Neither is birth in our control nor death in our control. The only thing that's in our control is what is in between those two milestones, correct? So even if somebody has cancer or any other deadly diseases, life-threatening diseases, it is still in our hands, not necessarily in that person's hands, but in the hands of the system, the community, to ensure how we live those few days. And we as human beings, I think the least we deserve to ourselves is a good, peaceful end to our lives. Who doesn't want this? It could be a successful man, it could be rich, it could be poor, it could be a thief, whoever, right? All of us deserve a peaceful and a smooth end to our lives. That is the only thing that a lot of us aspire for, right? So that is something that's very, very important. One unfortunate part that we have observed in India is there is a conflict of interest when it comes to palliative care, right? When people go to hospitals, most hospitals and doctors, unfortunately, do not refer patients to palliative care, right? They would continue to give them some kind of treatment in the same hospitals for reasons that we all know. And this is something that is slowly changing. Not all doctors and hospitals are like that, of course. A lot of them are doing a good job, but I think this is also one of the challenges, right? Because if they send them away to a palliative care center, you have lost a patient and you've lost a customer. Today, unfortunately, healthcare is a business. It's no longer just a service like what it was a few years ago, right? So that's another big challenge. And as you can see, there was one of the surveys that was done, which showed that for every 1,000 people, more than 6 people need palliative care in India, right? So the Sustainability Development Goal of the United Nations is 3.8. That's the goal that they want to achieve. And we have a long way to go to come down to that particular level. So approximately about 8 to 10 million people in India need palliative care every year, every single year, right? And there are slightly different figures. Some people say 4%, 3%, 2%, whatever, give or take 1 or 2 here and there. I think very low single digit percentage people in India have access to palliative care today, right, across the country, right? And as you can see that the chart on the right hand side, it's a little dated. This was a survey that was done in 2015 to rate the quality of death. Can you beat this? This was called as a quality of death index, right? And as you can see, India ranked 67 out of 80 countries, right? I'm sure if we do the same survey today, we'll probably be better. We won't be at 67, but probably we'll be somewhere in the 60s. Okay, 59. There you go. Yeah, that's last year, is it? Okay, 59. I was about to say that we'll be somewhere around there itself, but yeah, we are at 59. Not bad. That's okay, improvement, but we have a long way to go to come to where we should ideally be, right? This is also one of the reasons why a lot of people commit suicides, because they feel that dying is better than living with this pain and suffering. You're getting the point, right? They have not seen death. They have only seen this suffering, right? So strictly speaking, you can't compare. You don't know which is worse. But somehow, what you have seen and experienced is so bad that you would think that, okay, dying is better. And they will resort to suicides, right? Unfortunate. But if only they could be given palliative care, this can be prevented. They will not think of suicides, right? And one good thing is, while the national average is about 2%, 3% and all that, Kerala as a state has made tremendous progress in our country. And in fact, the penetration in Kerala is almost about 24, 25% to palliative care. They have made a lot of progress. They are miles away as compared to other states in India. Even in Karnataka, we have a long way to go, right? And we spoke about what are the different diseases for which palliative care can be given. It's not necessarily only for cancer, right? These are some of the popular or major centers in Karnataka. As you can see, the bottom ones are all, hospitals. There are many more hospitals. It's not an exhaustive list today. Unfortunately, every hospital worth its name will say they have a palliative care center. Palliative care department in the hospital. But I think there are very, very few institutions who are dedicated for palliative care and doing a good job. And one of them undoubtedly is the first one in this list, which is called Karunashraya, or the Bangalore Hospice Trust. Dr. Seema Rao is from that institution, and she will share more about what they are doing. But Karunashraya has been there for what, 25 years now? Okay, 94. I thought 98 or something like that, right? So, correct. Okay, right. So they started this journey of palliative care in the 90s, right, mid 90s, and they've had tremendous experience. And this is one of the very few organizations today who offers this care at no cost to people. Unlike all these names that you see at the bottom of the list, where it's just another service like cardiology or gynecology, palliative care, and people have to pay for it, right? So that's all I had to share, and hopefully this has given you some idea about what this is all about. And I'm sure when Dr. Seema talks to you, you will get to know more deeper details about how they give this care to patients at Karunashraya. If there are any questions, happy to take them once the session is done. Right?
Yeah, let's go further.
Sure.
Question and answer at the end.
Wonderful. Thank you so much. Yeah. Please.
Good evening, everyone. Thank you for this opportunity, Dr. Parmesh, Professor Srinivasan. It's a pleasure to be here today. I will talk about, one is basically about what our organization offers. As you see, Karunashraya, we call it the abode of compassion. So, yeah, so this is how Karunashraya looks at. This is I will show you a brief video on what Karunashraya offers.
Watching someone you care deeply for go through the stages of advanced stage cancer is incredibly tough. And I think Karunashraya was a lifeline during my journey as a caregiver. The world-class facility and positive ambience, coupled with skilled and compassionate care, provide a great sense of comfort, healing, and calm to patients at Karunashraya. Karunashraya allowed our family to shift our focus from aggressive treatments to making the most of the time we had left with our father. The home healthcare environment differs from the institutional environment, but we thank the team at Karunashraya for rendering exceptional care to our father, both through the home care channel and as an inpatient. Karunashraya is not just a hospice center. It is an institute that provides comprehensive end-of-life care with utmost respect.
This is what we do. As Mr. Nagarajan rightly said, it's a palliative care center as well as a hospice, right? So one of the distinguishing feature is that palliative care begins at the diagnosis of any disease. If there is suffering, that patient is eligible for palliative care, right? And hospice care is primarily end-of-life care. It is in the last 6 to 12 months of a patient's life. And there's another entity called terminal care, which happens in the last few days to few weeks of patient's life. So palliative care is the whole thing. Hospice care is in the last 6 months to 12 months of patient's life. And the terminal care is in the last few days to few weeks of a patient's life. So what we offer is, in our OPDs, we offer palliative care. So anybody at any stage of the disease can come to us for treatment. But admission, we focus on people who are in the end of life, because we don't have an ICU, we don't have a resuscitation facilities. So we focus on those who are nearing end of life. To clarify about euthanasia, I'm sorry, I needed to clarify those terms. Indian Association of Palliative Care strongly opposes the use of the term passive euthanasia, right? That is what we sort of advocate is, that is, euthanasia is giving medicine either to the patient, to end the life of a person. That is euthanasia, because of unbearable suffering. So euthanasia is always active, right? And withholding or withdrawal of life support like ventilator or cardiopulmonary resuscitation, I'm sure you've heard, do not resuscitate, is in a condition where the patient is unlikely to survive, is permissible in India, and that is not passive euthanasia. It is called as limitation of life-sustaining treatment. So it's two different entities. And in January 2023, Supreme Court of India has legalized this process of withdrawing and withholding life support in patients with terminal illnesses, and has set down a very detailed process on how to do it, right? And even if you have a terminal illness, you can decide whether you want to go through that process or not, and that process is called as a living will, so, or advance directive. So the court has legalized it, and the medical communities have come out with support for this sort of a medical directive, what we call it. I hope that is clear to everyone. Yeah, now going ahead, I'll tell you what we do in Karunashraya. I would like to talk about Jamuna. She was 68-year-old when she came to us. She had advanced cancer, which had, it was started in the uterus. She was operated, uterus was removed, but still the cancer came back. And it had spread to her lungs, it had gone to her bones, and it had gone to multiple areas in her abdomen. Now she was very ambulant, like you rightly said, it was advanced cancer, but she was doing quite okay. She was on taking palliative chemotherapy. The treatment to control the disease was going on. And she was told by her oncologist that despite the cancer was not responding to treatment. So this lady and her elderly husband came to us totally distraught. They were confused about what needed to be done next, right? They were not willing to accept that maybe she is, this cancer is not going to get cured. And along with that, because of the chemotherapy, she had ulcers all over her mouth. She was unable to eat. She had extreme fatigue, lack of taste and hunger. And there was the cancer that had spread to the bone was causing a lot of pain in her back. She was upset about her condition, not sleeping in the night as well. And they were not sure about what next. She had 2 daughters in Bangalore and the son was there abroad. Problem was the son had married a foreigner and they were not on talking terms. So now she comes to us and, we had to elicit all this information. So what did we do to help her? As he rightly said, what palliative care does is to alleviate suffering, reduce the suffering, not only of the patient, but of the family as well. We had to use medications to take control, to get control of her pain, for her hunger, for the anxiety that she was experiencing, for the nausea. We had to keep medications. And Karunashraya, fortunately, has one of the best well-stocked pharmacy, right? We have all opioids, what we call it, right? From morphine to fentanyl to methadone, we have all opioids with us. And these opioids are what we think can cause addiction. But in patients like these with excruciating pain, they have to be used. So first step was to manage her physical condition. The second step was to support Jamuna and her husband in making the right decision. What did they want, right? Were they willing to accept that disease was incurable? They were. Were they willing to accept that we couldn't control the disease? They were not. So we had to sit with them, discuss with them, and they went for a second opinion. And they decided to continue with the chemotherapy, despite the oncologist telling that it may not help much. Then we had family meetings with the son and the two daughters to understand where they were. The son-in-laws we included. Now Jamuna had this suffering. Why did this happen to me? Right? Why, you know, the spiritual distress. I have done nothing wrong in my life. Why am I being punished like this? And also the regret. She knew the disease has spread. She may not have much time to live. Now she has not on talking terms with her son. She was scared to, you know, talk about it because the husband was very strict. So we had to negotiate and walk around that. There were practical issues. The husband was exhausted looking after her pain, not sleeping in the night, taking her for chemotherapy. He was exhausted. So we had to look at that as well. Support the caregiver. Palliative care is not only for the patient, but for the family as well. So we had to look after that. And what we did was we asked the son-in-law to be more active in the caregiving, and we were able to ask her to shift into the daughter's house so that, you know, that, and they kept a nursing aide to look after. And then currently, how is she? She's pain free. She's going to the hospital for chemotherapy. No major side effects are there. Son has come from abroad now with his wife and they have reconciled. They are spending time together. All members in the family are aware of what is happening to her. We have spoken. Our home care team is visiting her on a week-to-week basis. What now is left is what will happen when she deteriorates. The oncologist has just yesterday spoken to me and told me she's not responding to this treatment to control her. She's getting progressively weaker. I think we need to stop chemotherapy. Now it is the due, you know, we have to now get back to them, get them on board about this, and, you know, start planning for the end of life. So this is what we were able to do. Do you think this would have been possible in a hospital setting? Yeah, would it have been possible? Right? That is when oncologists reach out to us to help them make these decisions, to help us talk to the family. Now I'll talk about another patient that we had, Babu. Babu was 40-year-old engineer. He used to chew tobacco. He used to smoke. He landed up with oral cancer. He had a very bad wound on his face. You know, it was smelling very badly. There was a lot of discharge coming in. He couldn't eat. He couldn't talk because it had eroded the whole cheek. So we had to put a tube through his nose to feed him, right? And he was divorced. A wife and daughter were in, and he was living alone. So his nephew, who was living in another village, brought him to us, right? And he had no place to go back to, right? And he was with us for almost 6 months. What did we do? We sort of took care of the wound. Of course, that wound is not going to heal because it is from cancer, right? But we managed to take care of the wound. And one of the things that he did when he came to us was he was telling us, please give me some medicine so that I can die. I don't want to go through this suffering. So we had to first take care of his physical aspects. We had to, you know, clean up the wound, stop the foul smell. We had to put in the dressing to the wound so that he doesn't look, you know, unsightly. It doesn't look very unsightly. And he was also very depressed. So the psychologist assessed him and found him to be depressed, referred him to me, wherein I had to start him on antidepressant medications. And we started engaging with him. Once his pain was under control, his wound was taken care of. For the depression, I had put him on medications. We were able to continue to engage with him. And we knew what Babu was. He was a very altruistic person who was helping everyone around. So we said, why not? You know, he was very mobile, ambulant. He was healthy except for this. So we started asking him to help us with taking care of the families, other patients, you know. And we also found that he was a very interesting individual who had gone through a lot of ups and downs in life and faced them very bravely. He was a very resilient individual. So we said, why don't you write your life story, right? There are things that you could write about. Where did you get your strength from to face all this? And why don't you write a letter to your daughter? They don't want to see you now. Who knows? Things might change later on. What are the lessons that you have learned from your life that you want to pass it on to your daughter? What is the legacy that you want to leave behind? So he made all these cuttings and letters. He wrote 3 books about his life. And we went through it. And as he started writing his life story, what we call, it's a kind of therapy that we do, he started finding some amount of meaning in why he was suffering like this, right? And he died peacefully in the hospice, and we supported the cremation rites, the nephew to conduct the cremation rites, etc. So this is another case of someone who was admitted in the hospice who died with us that I'm talking about. So as a person enters into Karunashraya, we sort of, the whole team embraces him. We talked about a multidisciplinary team. This is who we are. We are doctors. There are palliative care consultants like me. I do the double role. I'm a psychiatrist as well as a palliative care physician. Then we have more than 100 nurses and general duty assistants. Okay, so we have a ratio of 1 nurse for 2 patients. It's like it is in an ICU because the care that we provide is as extensive. We have physiotherapists. We are probably the only center in the whole of India, including institutions, which have a very strong mental health team. We have psychologists. We have psycho-oncologists. You know who psycho-oncologists are? Any idea? Who mental health issues, psychologists who deal with cancer patients, right? And I am the psychiatrist. We have social workers. We have a very strong research and education team also. It is not just enough to, provide service. We have to improve our quality. We have to, maintain certain standards. That's where we help, and we have volunteers. And it is not only the clinical team, but our public relations, the admin staff, the housekeeping, the security, everybody pitches in caring for the patient. They know how to talk to patients, how to care for patients. We train them, everyone, right from the security at the door to the doctors undergo a training on how to provide compassionate care. A wrong word by the security, patients can be distraught, isn't it? So how to respect and maintain dignity of the patient, of the person and the family members with us is what we strive for. We have evidence-based clinical care. We take care, we have antibiotics, we have antipsychotics, we have all medications that you will find in our hospital is there with us. And we use and we manage infections, we manage pain, we manage nursing. Our nurses are very skilled in managing. If you see cancer wounds, they can be very distressing. They can be very ugly to see, right? I remember once during COVID, we wanted a patient to be who had an oral cancer. We wanted COVID testing done on that patient. The guy who came to take the swab fainted seeing the patient's wound, and then we only had to take the swab and give him. But our nurses, are trained in managing this. And one of the things that we do is we are high on touch, right? If you see, there is the doctors and the nurses are compassionate, they care for the patients, and they respect the patient's autonomy and their choices and their preferences. We respect. The second is the psychosocial care. You saw the campus, right? What did you see? Was it like a hospital? There was, there's a lot of, it's over 6 acres in Bangalore with a lot of nature. So if you see the first picture, this gentleman was very fond of nature. He wanted to be under one particular tree. He would sit for hours together under that tree where there are a lot of mango trees, avocado trees, jackfruit trees, and some of them, patients enjoy, sitting underneath those trees, right? So connecting with nature. When you are in an institution or in a hospital, you stop living a normal life, right? We try to integrate them back into this normal life. It's about being with nature. It's about doing art and craft. It's about, dancing. And if you can see, if patients are not able to get up and walk, we bring the beds out. And this is a recreation room. If you see this, the last one, patients are lying in the bed and watching a movie, right? We screened Kantara. Many of the patients wanted it, so we did screen it so that they live as normal a life as possible. It is a home away from home for most of the patients. And we are a very secular organization, and this is the prayer spot that we have with, we have all religious symbol there. If the families want to pray, if the families want to meditate, we give them the choice of going into that place and sitting. And if you see these 2 books, these are for our patients that we have done. One of our patients, Sheila Mary, was a cook, right? And we have a therapy called leaving a legacy behind, which gives, when I die, what do I think? Just imagine, if I'm going to die, I want to be worth something, right? I want to leave behind something. Money though is there, but something productive for the others. So this legacy making was what was done here. She wrote the recipes of, some of those innovative recipes that she used to do. We published the book. Sorry, we published the book and gave it to her, right? And it gave her a sense of meaning and of being valued, right? And we have specific therapies for people in end of life called dignity therapy, meaning centered psychotherapy. So our counselors are trained in providing that. And we also look at death planning and death management. So as we said, hospice is a place where most people come to die. They are aware that they are dying when they come to us. So we, that, and certain people have different rites and rituals that they want, right? And we try to understand what is it that they want, what is the clothes that they need to wear, how is the body needs to be placed after death. We try to find out all their choices and preferences before the death happens, so that when the patients die with us, we sort of respect what the patient and the family has wanted. And this is the medical part of it that we do. We look at the symptom management, we look at communication, we look at support, psychological support. So the medical part that we do, and this is a room where we shift the patient once the death occurs, so that the family are able to perform the last rites. And you can see the ceiling of the room is like sky. It's painted like the sky. There are symbols, there are flowers kept, there are lamps kept. So the family can spend few moments of silence, respecting and do their whatever rituals they need to do. They can do it within the confines of this particular room. The crossing over room, we call this. And then we have for the staff, because we are dealing with people on a day-to-day basis who are dying, we also are traumatized because sometimes we grow attached to our patients, right? And the staff, the nursing staff, the counselors, the doctors also go through grief when we lose patients. And on a month, we have around 40 to 60 deaths in a institution. So people come with us to die. So seeing their suffering on a day-to-day basis has an impact on us. So we have a program called Vidaya. Every month end, we sort of respect those who have passed on in our care. We call out their names, we light lamps in their names, and we stand, observe a minute of silence, remembering their suffering, remembering their journey with us. And at the end of it, we speak about what hurt us. We talk about our grief. We, amongst ourselves, we discuss. And sorry. And this we hold, this sort of the final goodbye, we hold it every month. And of course, we have home care. If you see this photo, this is the lady didn't want the team to come to her house. So she would walk up to a shop in front of her house, and she would, our team would treat her there because she didn't want them to come, her neighbors to know about what she was having, right? So wherever it is, we can provide palliative care. Okay, this is our team going to the patient's house and doing the dressing. In addition, these white boxes that you see in the car are ration. So those who are poor, we provide food for them as well, rice, protein, etc. There is an organization that supports us. We also, if children need education, there is an organization called Mitra Foundation which supports us to educate the children of those who are dying of cancer. So we have various organizations who have partnered with us to provide the social care. And of course, this is our education and research wing. We also train doctors both in palliative care. We train volunteers. We have certain specific training courses that we offer. And we also have in-house training. We keep up to date with the latest in the field of palliative medicine. So our doctors, nurses, our counselors go through continuous training, and we are also a research center. So this is what Karunashraya is. It's a transformative journey from patienthood to personhood. Patients, we don't look at them as patients, but as persons. And it is a tranquility that we offer amidst the storm in the journey of their life. And we follow the platinum rule. Anybody is aware of what the platinum rule is? Anybody is aware of what golden rule is? Do unto others. That phrase, have you heard? What do you do yourself? That is the golden rule. What we look at is the platinum rule, which says, do unto others as they would want it done unto them. You cannot decide what they want. Our patients, our families decide what they want. And the ethos of Karunashraya is this. We go by what the patient and family preferences are. We treat the last phase of their life with respect and dignity. So that dignity in care, dignity in life, and dignity in death. That is what Karunashraya offers. Thank you.
Thank you very much. You all agree, wonderful talks we had for both of them, what you all doing about it. And also, Kerala comes first with palliative care and all this. This is some good news, as a matter of fact. Neonatal mortality and anything like that, you first match our national level, match the Kerala data, then you look for the other countries. We always quote that one. I think a lot of things can be learned from that one. That's what we are going to learn. We are students until our last breath. Let us be the students for that. And since the time is not there, many people have to go. And one question may be added later on when you have a picture. After that, you can ask any question, people who are staying here. Any questions? Okay. I think to conclude once again, I had 10 myths I quoted. You covered 6 of them. Other 2, the case history, other 4, you covered the drugs and all those things. I think you did a wonderful job. We sincerely thank you for coming over and entertaining us with your knowledge. We definitely develop these issues, in a matter of fact. And my personal example was when we had running, I was the owner of the Lakeside Hospital. In ICU, I started, any patient dies, the nurse and the IS is to get attachment to them. They'd cry. So we used to have a psychiatrist, psychologist, educating them, training them, how to associate, how to communicate that. These are all the issues we have to take care of it and all those things. I agree with you. And also 3-4 families. I made their house as the final stage of palliative care. The silk saris, heard of Patti saris? That's the biggest family in Karnataka. In one campus, there are about 150 people used to live in the family, different houses. And he was my tennis player. He used to play with me tennis in Century Club. And he had cancer. And brain cancer. As operated, secondaries came. I said, you cannot, sir, he's going to have breathing problem. We just want to put him a ventilator and all these things. People are against that. Sir, once he said, Dr. Parmesh, I don't want the needle. I don't want to put anything here. I want to die peacefully in the house. Can you do something about it? Yes, we did it, educated them. We avoided the intensive treatment. And in his house only converted into intensive care, the suction machine, 24-hour oxygen, and the feeding tube. Doctor can go every week, change the tube from here to here. He's supposed to die without that one within 48 hours. He lived about a month and a half. In his bedroom only with his family, he died peacefully when the people put the water at the end also. And this is one of the issues. We can do it. So these are all some of the examples. This type of thing, as a token of appreciation, sir, we like to have a small memento. Please accept us, both of you. Joshita, yes, sir, Professor Srinivasan, please handle. Afterwards, let's have a picture together. Thank you.
Thank you, everyone. Thanks for your time.
I'm not sure. Do you want like this or get the order? What the next order? Is it there or?